for coming to the webinar. I'll be giving the presentation in English because we decided that presenters should speak in the language that they're most comfortable in. Mais si vous voulez poser des questions en français à la fin de la présentation, je serai heureuse de vous répondre en français. So today I'll be talking a bit about some of the research that we've been doing over the last many years on pregnant women and their unborn children during population-level natural disasters. So as we know, as is becoming increasingly evident, climate change is stressing populations. It's stressing populations by increasing the frequency and severity of weather events across the world. So with climate change, we have more heat waves, more droughts, wildfires, heavier rainfall, more storms and superstorms, hurricanes and typhoons, and many of these are leading to floods. So floods are the most frequent of all natural disasters and kill thousands of people every year across the planet. There are a number of health effects of floods. In terms of immediate danger during floods, of course, being exposed to toxicants in floodwaters and waterborne microbes present dangers. Of people who die during floods, 2/3 of them die by drowning, and another third by other kinds of injuries. There are a number of delayed effects as well. So mortality increases by about 50% in the months following a flood. And then the mold and respiratory infections that can occur will also influence the population. For example, hypertension can double in the first month of following a flood. Some of the most devastating effects of floods are on mental health. So one can see increases in distress in the population up to 2 years following a major flood. Women, by the way, happen to be most vulnerable to post-traumatic stress disorder. And if we look at women who are actually pregnant during floods, there tends to be about a threefold increase in preterm births following floods. There's a 40% increase in fetal death, and there are effects on the unborn child's development. And that's pretty much where I come in. So how would this work? How would a disaster that happens during pregnancy influence the child's development? So we know that during any natural disaster, in the population in general, there are mental health problems. There is greater anxiety, there's depression. A lot of these lead to unhealthy behaviors such as substance use, domestic violence, and that sort of thing. If a person is pregnant, if a woman is pregnant, then these unhealthy behaviors can have, as we know, a direct effect on the development of the fetus. So just think about alcohol syndrome, for example. We also know that mere exposure to disasters during pregnancy can also increase risk for preterm birth, which carries its own problems for the future of the child. And we know that that during a natural disaster, a person's, for example, a woman's stress hormones would increase. These can influence the placenta, which can then influence the development of the fetus. And between the direct effects of the disaster on the fetus and the effects of preterm birth, then there are increases in mental health problems. There's implications for cognitive development of the child, obesity, and diabetes. And of course, growing up with a mother who may still have mental health problems from the disaster in pregnancy is also another negative influence on the development of the child. So when we're talking about stress, maybe stress from a natural disaster or stress from any other kind of event, what do we really mean? The term stress gets tossed around for a number of different situations. So Lazarus and Folkman put together a model of what is stress. And that would start with an objective situation or an event. Then the individual goes through a 2-stage cognitive appraisal process. So in the first stage, they determine, is this event, is this actually a threat to me? They might decide that no, this is not a threat, so then there's no stress. If they say, yes, this is a stress, then they go to a second phase of cognitive appraisal, which is an evaluation of the extent to which they think they've got the resources or the ability to cope well with this threat. If the person suggests, or if they conclude that, yes, I've got the resources to cope with this, then they would be experiencing positive kinds of stress. But if they conclude that no, they may not have the resources that are required to deal with the stress, with the threat, then that would generate subjective distress, would generate cortisol, and then in the case of pregnant women, that cortisol could go through the placenta and influence the development of the unborn child. So how would you study this kind of a model of stress with the objective, the cognitive, and the subjective aspects of stress in pregnant women? We cannot subject them in a natural experiment, or in a real experimental kind of session to stress. So using natural disasters is a good model, a good natural experiment that can be used to study prenatal stress in humans. So I've been doing this for about 22 years or more. I started studying women who were pregnant during the Quebec ice storm of 1998, followed that up with a study of women who were pregnant in Iowa during the flooding of 2008, and then in Australia and Queensland in 2011. We are also studying women who were pregnant during the Fort McMurray wildfires of 2016, and women who were affected by floods in Houston, Texas, following Hurricane Harvey in 2017. So what we've been doing in every one of these studies is essentially trying to test this kind of a model, where we're looking at how these different aspects of prenatal maternal stress, the objective, the cognitive, the subjective, and the timing of the stressor in pregnancy, how it influences the mental health and other kinds of illness and development in the children who are exposed in utero. But then we also want to know, what are the mediators, or what are the mechanisms by which we have that kind of an effect? Are these effects generated through effects on epigenetics, like DNA methylation, or on the development of the offspring's brain, or other kinds of mediators? We also want to know, between the prenatal stress and these outcomes, are there some kinds of intermediate phenotypes? So these would be precursors during early childhood that could lead to mental health and illness problems later in life. What we also want to know are, what are some of the moderators? In other words, are there variables, are there factors that determine who is most vulnerable? So are the effects of prenatal stress on the unborn child specific to boys or to girls? Is it specific to the timing in pregnancy of the disaster? And is there a dose-response effect? In other words, do we see that the more severe the stress, the greater the effect on the child? Or is it just exposure to the flood or not having an effect? So then how do we assess these variables? So in all 5 of these prenatal stress disaster studies, we've been creating scales to measure the objective hardship that women go through. So in the disaster literature, they talk about different components of the disaster experience, including threat. So we would ask, has the woman been injured by the disaster, or a loved one injured, or was the woman in danger from drowning, electric shock, contamination, that sort of thing. We look at measures of loss, including damage to the home or lost income. We also look at scope, and there are 2 main aspects of scope. There's the duration, and then there's also the extent to which the surrounding neighborhood has been affected. And then we look at change, because all manner of change is inherently stressful. So the extent to which the family was able to stay together during the disaster, if they changed residence, work routine, prenatal care, that sort of thing, was altered. We also look at subjective stress, and we look at 3 different aspects of the mom's subjective distress from the disaster. First, we look at their current, at the time of recruitment, their current post-traumatic stress type symptoms, which would include avoidance of thinking about the disaster, intrusive thoughts and images that come into mind because of the disaster, and then hyperarousal symptoms. So these would be questions like, whenever I am reminded of the disaster, my heart beats fast, or my palms sweat, that kind of thing. But then it's also very important to look at what the person was experiencing at the time of the disaster itself. And so we have questionnaires that ask the woman at the time of recruitment, so this could be 6 months to a year after the disaster, to think back, how are you feeling at the time of the disaster? So we have questions about their level of distress at the time of the disaster, and also dissociation types of symptoms. So dissociation in psychology is a condition where it's a bit like daydreaming. So a very mild form of dissociation is when you're kind of not really thinking about where you are and what you're doing, but you're sort of absent and you're daydreaming. But this can become quite severe in some situations where the person is totally absent from their current surroundings. So we measure these 3 aspects of the women's subjective distress. We also look at their cognitive appraisal, and we've been using this one item in our questionnaires. So taking into account all of the effects of the flood on you and your family, what would you say have been the overall consequences of the event? And the woman can choose between very negative, negative, neutral, positive, or very positive. This actually is the distribution following Project Ice Storm, or following the ice storm crisis in 1998, where we saw that a lot of women actually found it to be either to have no real consequences on them and their family, or actually to be positive. And very often that was because they were having very positive, friendly interactions with family during that time. So the model that we test is looking at these different aspects of prenatal stress: the objective, the cognitive, the subjective, also the timing of the disaster in pregnancy. We look at some immediate outcomes like preterm birth or birth weight, because these can have their own consequences down the line. We spend a lot of time assessing the children as they grow and look at their physical development, including things like their insulin secretion, BMI, the heart rate variability, that sort of thing. We look at their cognitive development, their IQ, their language, attention, and so on. We look at their behavioral or psychological development. This would be anxiety, depression, autistic-like symptoms, that kind of thing. And also their motor development, including balance, coordination, visual motor integration, and so on. And then what we're hoping is to be able to follow these children long enough to where we can look at their psychopathology and their cognitive development as young adults. Then we also have a number of covariates and other potential moderators that we take into account, including the mother's own anxiety and depression as the children are aging. We look at the socioeconomic status, the coping style, social support, and so on. And so from the flood studies that we've been doing over the years, so the Iowa flood and Harvey in the United States and the Queensland flood study in Australia, we have found significant effects of all of these aspects of prenatal stress. So for example, we find that when the floods would have happened early in pregnancy, that we had effects on obesity when the children were 2 years old. If the flood happened in the second half of pregnancy, then we generally had problems. We saw problems on motor development and also IQ. We found that the objective exposure of the women, so their objective hardship, their threat, loss, scope, and change as a function of the flood influenced cognitive, behavioral, motor, and physical development of the children. The subjective distress of the mothers has also proven to be a predictor of the children's cognitive and motor development, and even the woman's cognitive appraisal. Remember their answer to this question about what were the consequences of the flood on them and their families as negative, neutral, or positive. Even this is showing effects on the children's development. So I'll just give you a few examples. Here's an example from the Iowa flood study. So we looked at the children's cognitive development at the age of 2.5, using an interaction, a face-to-face assessment of the child called the Bailey scales. And as you may know, the mean IQ is 100 with a standard deviation of 15 points. So this area right here would be one full standard deviation below the mean, and we've got almost a full standard deviation above the mean. And these lines here are just illustrating the effects of the timing of the stress among women who had low subjective distress. This is for moderate, and this is for high levels of subjective distress. So what we found was that only from about mid-pregnancy, from very early to the beginning to mid-pregnancy, was there an effect of the mother's subjective distress on the children's IQ. So the more severe the stress, the mother's stress, the lower the IQ. However, the effect of the mom's subjective distress got lower and lower, or less and less, the later in pregnancy the flood happened. So by late pregnancy, by the 3rd trimester, there was no effect of the mother's subjective distress. So this is showing the effect of both the timing and the mother's subjective distress on the children's cognitive development. We also looked at motor development. These data are from the Queensland flood in Australia. This figure over here is looking at fine motor development, and this is gross motor development at the age of 16 months. And unlike what we saw for the cognitive development, here we're seeing that exposure to the flood in late pregnancy seems to be a vulnerable period for motor development. So in this case, we're looking at the post-traumatic stress symptoms, and we see that when the PTSD symptoms in the mother were severe, that the later and later in the pregnancy that the flood happened, the lower or the worse were her child's fine motor development. So it really is only in late pregnancy that we see that the more severe the mother's PTSD symptoms, the worse the child's motor development. But there's no effect on motor development back here early in pregnancy. And we find something similar with gross motor. Here, just to illustrate that cognitive appraisal, the way the mother thinks about the natural disaster has an effect. Here we're showing that, once again, we have a late pregnancy period of vulnerability, but in this case, if the mother had neutral or positive appraisal of the flood, there was no effect on motor development. But if she had either neutral or positive, if she had, so this is neutral and positive, there was no effect on the child's motor development. But if she had a negative appraisal of the flood, then there was a definite negative effect on her child's gross motor functioning at age 16 months. So one of our PhD students in Australia, Katrina Moss, tried to put all of this together, again looking at fine motor development in children at 2.5. And she wanted to know, well, how does the objective hardship and the mother's distress, how do they work together? Is there some kind of a cascade of effects from the objective hardship through the paratraumatic distress, PTSD symptoms, and so on? And what she found indeed was that the more severe the objective hardship, the threat, the loss, the scope, the change, the more severe was the mother's peritraumatic distress. Now, this is her thinking back about how distressed she was at the time of the flood. So this peritraumatic distress was also associated with now, at the time of recruitment, how severe the mother's post-traumatic stress type symptoms were. So greater distress, greater symptoms. We also see a direct effect from the mother's objective hardship from the flood on her PTSD symptoms at recruitment. But all of these variables, the objective hardship, peritraumatic distress, and PTSD symptoms, seem to be operating through the PTSD symptoms on the children's fine motor development. So what can we do? Okay, if we've got a flood like the flooding in Houston following Hurricane Harvey, there were 72,000 births every year in Houston. What could you possibly be able to do to counter a population level disaster, to try to minimize the mother's distress and hopefully improve the outcomes in their children? Well, we got a bit of a chance to look at what kinds of interventions might be important when we did the QF 2011 study in Australia. So we piggybacked our study of the flood in pregnancy on a pre-existing randomized control trial of 2 forms of midwifery practice in Queensland. And it helps to know that in Australia, all babies are born with the aid of midwives. So in hospitals, it's midwives rather than nurses that are there to assist with the delivery. And doctors only come in if it's necessary. So these 2 kinds of prenatal care, group midwifery practice is a practice in which there's continuity of care. So every pregnant woman has a primary midwife who they see at each visit, but that midwife is also in a group with 3 or 4 other midwives so that the pregnant woman gets to know all of them. That way, at the time of delivery, even if she doesn't have her primary midwife there for the delivery, she has a midwife who knows her and is familiar with her particular case. So there's good continuity of care. This was pitted against standard care, in which pregnant women go to the clinic and they are seen by whichever caregiver, whichever midwife happens to be there at the time. So the hypothesis was that women who were in this midwifery group practice during the floods may have received better social support, better care that would have an influence on the women's mental health. And indeed, that's what we found. We found that for women who were in standard care, so no continuity of their care providers, that the more severe their objective hardship from the flooding, the greater was their level of depression in the postpartum period. So they were very subjected to, or very vulnerable to the level of objective hardship. On the other hand, the women who were in group midwifery practice, their levels of depression and anxiety actually stayed fairly low, and it didn't matter at all how severe their hardship was. And in the Queensland flood, the women with high levels of hardship, they lost their homes, and yet they were buffered from postpartum depression by having better prenatal care. So we also wanted to know if this would have an effect on the child's development. So we looked at the children at age 6 months. Their mothers answered questionnaires, and we saw that pretty much across the board, there was better development in the children who had been randomized, remember, to the group midwifery practice. We had significantly better performance on fine motor and problem solving in the infants who were in the group midwifery practice. So this was definitely a positive outcome of this trial. So that's what one might be able to have by changing the healthcare system. But in light of how long that would take to actually do, what could we do to jump in very quickly and do something immediately after a disaster or during a disaster to try to reduce women's levels of post-traumatic stress or depression? So with Hurricane Harvey, we adopted a long-standing intervention that was developed and tested over 30 years called expressive writing. This has been promoted and tested by James Pennybaker from the University of Texas at Austin. And essentially what we did was Hurricane Harvey occurred in August 2017. We started to recruit women in February 2018. We recruited them, we tested their mental health through questionnaires. Then they did an intervention, and then we reassessed their mental health 2 months later. Now, the intervention for the expressive writing, women were asked to write online for 20 minutes a day for 4 days, and to write about their deepest thoughts and feelings about their fears of the flood on the first day, about various relationships, about the worst trauma they ever experienced in their lives, about the worst conflict that they're going through right now. Then a second group was randomized to neutral writing, and then a third group had no writing whatsoever. So our preliminary analyses of these data were not encouraging. In other words, we see that there really is no difference here, no significant difference in terms of their level of depression at the time of recruitment, but all groups had a significant reduction in their depression over time. And there was no greater reduction. We would have hoped that the reduction for the women in the expressive writing would have been greater than that in the other groups. And so far, we have not found that. We have cleaned up the data set, and we will be reanalyzing these data. But for now, this does not look like a promising intervention post population level disaster. So what other things might be done? So in the United States, they've taken a bit of a different tact. The U.S. Center for Disease Control, the CDC, created a multidisciplinary cross-agency group to address the needs of pregnant women and newborns following disasters. They created a number of materials that could be used by anybody, anytime. It's all downloadable from the CDC. They've got a fact sheet for pregnant women who are being evacuated. They have pre-prepared public service announcements for pregnant women to hear, and they've got a lot of documentation for first responders and people in public health. So for example, these are screenshots from their website. They have a toolkit with a number of questionnaires and planning criteria. They've got training and implementation tracking. So they have this system that's set up. I have not found out at this point the extent to which there has been uptake of these toolkits, nor whether or not there's any evidence that it improves outcomes, but at least there's this policy. So I had a student do a search for any kind of similar policy or toolkits in Canada and in Quebec, and this is what she found. Nothing at all. So I think we've got a bit of work to do on this front. So just to wrap up a bit, this is the figure that I showed you at the beginning, where exposure to a natural disaster can influence the mother and her own mental health. It also influences the development of the baby in terms of their mental health, their cognitive development, obesity, and so on. But I just want to leave you with a thought that will really emphasize the importance of taking care of pregnant women and their unborn children during a disaster. And that thought is this, that inside this fetus, if it's a girl, she are all of the eggs that she will ever have in her lifetime. And so the effect of the flood is not only developing her brain and having effects on other areas of her physical development, it seems also to have an effect on her reproductive system. If it's a boy, then he has the fetus has the cells that will generate all of the sperm that he will have in his lifetime as a man. And so a single event during the pregnancy of a woman affects not only the woman, but also her child, but also all of the grandchildren that will come from that pregnancy. So all of these grandchildren may also develop problems with mental health, cognitive development, and so on. In animal models, we don't know too much about in humans, but in animal models, we know that stress to a pregnant female can be seen in the development 4 generations down the line. And so I think this is a real call to, a wake-up call for taking care of pregnant women during disasters. So in conclusion, we all know that climate change is increasing the severity and frequency of natural disasters. There's good reason to believe that every disaster is affecting 3 generations, so pregnant women, their fetuses, and all of the grandchildren from that pregnancy. We know that every aspect of stress is important, whether it's the degree of objective hardship the women are going through, whether it's their subjective level of distress or their cognitive appraisal. So each of these aspects of the stress are areas that we can be concerned about during natural disasters and try to intervene for pregnant women. We also know that every moment from conception to birth is a vulnerable period for something in the development of the unborn child. We also see that it doesn't take that much stress. The results that I showed you from the Iowa flood or from the Queensland flood, the levels of stress in these women were not that high compared to the stress levels from the wildfire and from the ice storm. Potentially because in the wildfire and the ice storm, the entire population of the community was affected, whereas in floods, it tends to be limited, the effect tends to be limited just to the areas around the bodies of water. And so help can come from other areas of the community. So if we're seeing this level of effect from floods, then we can only imagine what would be the level of effect on the unborn children following something like a tsunami or an earthquake that is much more severe. So for sure, natural disasters and the effects on pregnant women is expensive for Canadians. Just looking at increases in preterm birth and low birth weight is very expensive. And then looking at the mental health of children and their slightly lower cognitive development is also expensive. So I think one thing that we could talk about during the question and answer is, are we doing enough to protect pregnant women and their unborn children during floods? So this is one reason why I was very pleased and excited to become involved in the RISK network. This is the Quebec Intersectorial Flood Research Network, in that with its goal of protecting Quebecers and the Quebec territory from the effects of floods, that the intersectorial part is that I would be able to interact with people from the Red Cross and from public health and try to evangelize, if you will, for pregnant women and their unborn children. So given that this is April 24th, 2020, and we are all in lockdown from the COVID-19 pandemic, I thought I would say a word or two about COVID-19. So if we think about the components of stress that I talked about, the threat, the loss, the scope, and the change, we have plenty of that right now across the board. So in terms of threat, we're constantly being bombarded by reminders to wash our hands, to wear a mask, to stay at home. So there are threat messages that are hitting us all the time. And the threat is real, as we all know. The loss, there are severe losses, especially financial losses for people who have seen their income limited or even disappear altogether. Obviously, change is everywhere, and scope. So one of the things that we've seen is that scope is an important aspect of prenatal stress. And what we see with COVID is that the duration is long. Who knows how long it's going to go on? It's a big question. It's a worry. And also, not only is the entire region affected, the entire globe is affected. You cannot get away from this. So there's good reason to think that the stress around the COVID-19 pandemic will have global implications for the development of unborn children. In terms of pregnancy and COVID-19, one thing that we know is that any kind of an infection during pregnancy is associated with increased risk for a number of outcomes for the fetus. So pregnant women definitely need to do everything that they can to limit the threat of being infected. One of the things that we're also seeing is that because of COVID-19, prenatal care and birth plans are changing. Prenatal education classes are being canceled. Maybe they're online, but that's not quite the same. Birth plans are changing. I got an email from a pregnant woman in New York City who was freaking out because her hospital and all of the hospitals in New York had decided not to allow partners, not to allow their husbands into the delivery room. So the women would essentially be alone except for nurses and doctors coming in and out, but they wouldn't have a partner there with them. We know that objective stress is mostly out of the women's control. We know that subjective stress at this time is normal, but of course there's variation in there. But we can help women think more positively, have a more positive cognitive appraisal of COVID-19, of the pandemic, in terms of being allowed to stay at home, maybe spend more time with spouse, maybe learn a new language. You know, there are a number of different ways that we could spin what's happening to us in positive ways. So this is a webinar for the Risk Flood Research Network. And so, of course, we have to think, what is going to happen if we also have flooding? So if we add flood stress onto, already we've got the COVID-19 stress. So will we be in a position where we can really protect women, pregnant women, in the event of floods and maintain social distancing, maintain good public health directives? So there's so many people to thank for all of this work over the years. If I listed all the names, they'd be so tiny you couldn't see them. There are many people that I need to thank. So thank you very much for your attention.